Honorable Chairperson, respected teachers, and dear audience, welcome you all to my presentations. My presentation is entitled In-Stent Restenosis in Left-Main Bifurcation Lesions. So, what to do? My case regarding 38 years old gentleman who presented to us with the history of non-STMI, for which he underwent a PCI2 LAD 8 months back in an outside hospital. Now patient comes to us with the complaints of effort angina, which was refractory to the optimal medical therapy. ECG shows anteroseptal ischemia and echo reveals normal. Here is the 12-lead ECG showing anteroseptal ischemia. Here is the previous CSG of the left system showing 90% stenosis in Frogs LAD, and OM is also diseased. There is 90% stenosis in OM, first OM. Here is another view showing the same findings. Previous CSG of the right system reveals normal. So previously, PCI2 LAD was done by 2.75 into 23 millimeter drug-eluting stent at 10 atmospheric pressure. Here is the final view after PCI showing TIMI grade 3. So patient come to us with the chest pain after the 8 months of PCI. So what should we think? Is it due to new lesions or ISR or stent thrombosis? To resolve this issue, we proceeded to check angiogram, and check angiogram shows the distal left main seems to be diseased, and there is 99% osteoproximal lesion in the Frogs LAD and ISR involving the LAD, and LCX is also diseased, and there is still disease in the OM1. Here is another view showing the same finding. Right systems reveals normal findings. So our final impression of the CSG was this is a case of left main distal bifurcation lesions involving LAD and LCX with ISR in LAD. So what should we do now? Should we go for CABG or PCI or heart-time approach? To assess the lesion severity, we calculate the synthesis score of this patient, and it was 28, in which CABG was class 1 indication and PCI was class 2 indication. So we counsel the patient about the risks and benefits of the both procedures, and patient categorically denied to undergo CABG, so PCI was planned. Here is the algorithmic approach to bifurcation lesions. I skip this twice for time shortage. So if we assess our lesions, this is bifurcation lesion, that is Medina 111. This is true bifurcation lesions, in which side branch is LCX is having significant lesions and diameter is more than 2.5 millimeters. So we go for up-stent, two-stent strategy. And we assess the angle between the main branch and side branch. The angle is more than 7 degrees. So we preferred for tap technique. Here is the diagram showing the step-by-step procedure of the tap technique. So here is the procedure. After engagement of the left main catheter by engagement of the left main by 7-phase catheter, wire was negotiated into the both LCX and LAD. After wiring, free dilation for LAD was done by 2.5 into 12 millimeter balloon at 12 atmospheric pressures, and LCX was free dilated with 2 into 10 millimeter at 12 atmospheric pressures. As this is a case of left main bifurcation lesions and also a ISR case, so we went for IVAS run, that is class 2 indication in this patient, and catheter pullback from left main to LAD shows, LAD to left main shows there is ISR for which the region was stent under expansion in the LAD, and MLA of left main and ostial LAD was also reduced. Here is the IBAS catheter pullback from LCX to left main showing ostial circumferential flag in LCX. So 3 into the 32 millimeter drug-eluting stent was placed over the left into LED at 6 atmospheric pressures. Then wire was removed from the LCX and also recrossed the LCX to the distal stent stud. And finally, stenting was done into the LCX with the balloon in the left into LED. And final kissing balloon was done. And finally, port was done by 4 into 8 millimeter balloon at higher pressure. And post-procedural, I was showing adequate stent expansion and all of us stent start, and there was no stent distortion, and MLO was also achieved. Here is the final result after the PCI, showing optimal result. Here is the hardware used in our case. And after the procedure, patient was hemodynamic stable and his hospital was unremarkable, and he was treated with Ticarabet's DAPT. And on follow-up at 12 weeks, he was symptomatically improved. Here is the slide. I skipped this slide for time shortening. In our case, this is the classification of ISR, and in our case, it is type 3 probability. And here is the risk factor. In our case, bifurcation and osteal lesion, and stent under expansion was the cause. And here's the management. And take-home message is, in case of left main disease, if we have enough expertise, hardware support, and left main territory is favorable, PCI would be a choice. And restenosis with the angina ischemia should be treated with repeat revascularization. That's all from my presentation. Thank you.
Thank you, Dr. Mamun.